Thank you so much, Christine and Atupele. Good evening, everybody. Our talk for the day is renal artery Doppler evaluation. And I've chosen to be specific for patients with hypertension. Right. I hope everyone is hearing me clearly. So those guys in Zimbabwe, if I lost, if I'm not available on the waves, please you can contact me on my phone. Otherwise, I may be presenting on myself for the next few minutes. Okay. So in this presentation, I'm going to look at introduction and some key and basic knowledge about hypertension and renal Doppler evaluation. I'm going to touch a bit about the anatomy of the kidneys and the renal vessels. I will be also looking at renal artery anomalies and diseases. I also look at the technique and protocols that are expected when doing this examination. And I will touch on the criteria for renal artery stenosis. Okay, so with hypertension, there is usually, as a result, it results from the narrowing of the renal arteries. So what happens with the renal artery narrowing is the kidney wrongly senses this as a reduced flow to the kidneys, and it wrongly senses it using the juxtamedullary apparatus as if there is low blood pressure in the whole body. So because of the reduced flow to the kidneys, it will release renin that will convert angiotensin to angiotensin 1, and then angiotensin 1 is converted by assistance from the angiotensin converting enzyme, which is found in the lungs, to angiotensin 2. So the angiotensin 2 is the one which is responsible for vasoconstriction, and it also results in the release of aldosterone, which will cause sodium and water retention. All these factors will give rise to hypertension. Okay, so this is part of the pathophysiology of what will cause hypertension in a patient with narrowed renal vessels. Why do we use ultrasound? Right. As we know, the gold standard of this renal artery assessment is CT angiography with contrast, but this procedure is a bit expensive, is also invasive, and is not easily available as compared to ultrasound. And it cannot also be used for screening. It is not ideal to use radiation and all these its disadvantages, including the price to screen patients with hypertension. But ultrasound is non-invasive, is very cheap, is readily and easily available. It uses non-ionizing radiation, and using ultrasound, we can also be able to look at the anatomic and physiological information about the kidneys. We can also evaluate the hemodynamics of the renal vessels using ultrasound. So all this is what makes ultrasound evaluation with ultrasound evaluation of the kidneys very important and very useful in the medical field, especially for hypertensive patients. So what is important in renal vessels evaluation, specifically the renal arteries, is the patient preparation. There is need for proper patient preparation. There is need for using optimum equipment with very good Doppler sensitivity. And also the operator needs to be a bit experienced or should know the basics that are very important in doing this examination, and should be also well versed in technical shortcuts that enhances proper evaluation of the renal vessels and to come up with a good diagnosis that is useful to the patient and the physicians. However, it has its own limitations for example, if there's poor preparation, I usually recommend to do renal Dopplers in the morning before there's too much bowel gas, because bowel gas usually accumulates in the morning, in the afternoon, and as the day goes by. So it's very, very useful to book our patients early in the morning and do the Dopplers. It was also a bit problematic in obese patients and also in uncooperative patients. I still remember I once have one of my clients who was, I don't know which word can I use, was mentally, I don't want to use the word psychiatric patient, but maybe mentally handicapped. He was restless. He could not even manage to sit on the bed. By the time we touched the probe, he could be frightened and think he want to do something bad. He would woke up on the bed and start crying. So those kind of patients, they are actually a problem to do. Sometimes you may need to sedate the patients, but with these patients, the doctors were also reluctant to do so because they were not sure about what is happening in this patient. Also in patients with respiratory difficulties, because you are going to use breath holding techniques as you doing the examination so that you can have better visualization of the kidneys. Right, on anatomy, we are going to look a bit on the origin of the renal arteries. The renal arteries arise from the aorta and it heads towards the renal hilum. Once the renal artery enters the kidney, it divides into segmental arteries, usually around 5 segmental arteries, which will then divide into interlobar, and then the arcuate arteries at the cortex of the kidney, and the interlobular as well at the outer reaches of the cortex. So the right renal artery, usually this is what is usually important. I will show you on the next image, but you have to know that the right renal artery is posterior to the IVC, and the left renal artery is sandwiched between the aorta and the superior mesenteric artery. Right. From that image, I want you to memorize a few basic things. I think you can see that the renal vessels are anterior to the renal arteries. That's one. The other thing is the right renal artery is behind the IVC. The IVC is the one in blue, and the right renal artery is behind it. And also the left renal artery, it goes anterior to the aorta and is sandwiched between the superior mesenteric artery and the aorta, right? This is important because you will see as we go, we will start talking about the Craig-Nut syndrome and some of the findings that we do, because you also need to assess the left renal vein. So there is differences in the waveforms of the left renal vein to the right renal vein, which may be related to this arrangement of the vessels in the abdomen. Okay. This is another diagram which just shows that the right renal veins are anterior to the renal arteries. So this is just another diagram which is illustrating the arrangement of the vessels at the kidney hilum and within the kidney. You can see that there's the renal artery, which is dividing into segmental arteries, then interlobar arteries, arcuate arteries to the outer cortex as we move from the renal pelvis to the outer cortex of the kidney. We also have anatomic variants that I put in pictures there. This should not confuse us when we see them when we are doing our scans, because we may find an upper accessory artery and then you get confused, what am I seeing here? So there are also variants in the arrangement of the renal vessels. Our variants will include an upper pore accessory artery. We will also have a lower pore accessory artery, which is arranged in the same way as the upper pore accessory artery there. These arteries usually arise directly from the aorta to the upper pore of the kidney. We will also have an inferior suprarenal artery, right, which may arise from the renal artery going to the superior part of the kidney or to the adrenal gland. We will also have a prehilar branch. This one can arise from the renal artery and goes parallel to the renal artery, entering into the hilum of the kidney. I don't know, there's someone making noise. Okay. So from the prehilar branch, we also have the polar arteries, which are found in the lower part of the kidney arising from the inferior vena cava, right? So these are some of the variants that you will see. You also have a retroaortic vein. Remember we said the right renal vein is sandwiched between the superior mesenteric artery and the aorta. There are also some cases which are normal variants when this renal vein doesn't come anterior to the aorta but goes posterior to the aorta. Right. So
sorry, Miss, do you mind just making it a slideshow?
Okay, that's fine. Okay, okay.
No problem. Thank you.
Right. So I'll move on to renal artery disease. Right. We usually have two common problems with the renal arteries. The first one being the renal atherosclerotic arterial disease, and the other one being fibromuscular dysplasia. These two conditions usually result in hypertension and ischemic nephropathy. Okay. So the causes of hypertension, which are also equated to just increase in the resistance in the renal arteries, because that's what simply causes renal hypertension, right? These include renal artery stenosis as the major cause, and this can also be due to renal parenchymal disease. This can be due to obstruction of the renal vessels, which can be either the renal vein or the renal artery. Both of them can cause hypertension. It can also be due to pyelonephritis, renal vein thrombosis. It can be due to renal masses compressing the renal vessels. It can be due to renal infarction, or it can be due to renal injury and transplant. Right. Now I'm moving on to the protocols of doing renal vessels evaluation for hypertension patient. Right. So our protocol usually involves proper preparation, which involves fasting for 12 hours. Then we need to use a low frequency transducer of 2 to 5 megahertz. And we usually use two positions, which is the supine and the lateral decubitous. So we can also call them the anterior approach and the flank approach. However, if there is problem with maybe gas or something, we are not clearly seeing our vessels, we can also use the prone there as a modified technique. Then we need to use breath holding techniques. So my protocol I just categorized into a system of two, whereby we have two approaches that I was talking about, the anterior and the flank approaches. And we also have two criteria of evaluating the kidneys, which is the direct survey and the indirect survey. So on our indirect criteria for renal artery stenosis, we are looking at the kidneys. Here we are evaluating the kidneys, and we are trying to sample from the vessels within the kidney, from the hilum to the cortex, what are we looking for? We will be looking at the waveforms that we get there. So on our indirect criteria, we are trying to look at the kidney to see if there is any effect to the intrarenal vessels that may even emanate from the main renal arteries. So we will sample from the upper pole, the middle pole, and the lower pole of the kidney, and we can also sample at the renal hilum. So what are we looking for? We are looking for a Pavas status waveform, which shows that there is high resistance within the arterial bed of that kidney. We are also looking at the kidney in general in the indirect criteria, whereby we look at the renal asymmetry, which is the size of the kidney themselves. Are they in normal size? Usually, if there are problems with blood supply or to the kidney may shrink in size. So we are looking at smaller kidneys or a difference of more than 2 centimeters, in which case you have to interrogate the smaller kidney. Since we get the waveforms, we can also look at the resistive index and the acceleration time, which should have values more than, shouldn't have values more than those stated. The resistive index should be less than 0.7 always. If it's more than 0.7, it means there's higher resistance in the renal vessels. And the delayed acceleration time should always be less than 0.07. Then on the also on this indirect criteria, you can even look at the kidney echo texture, right? Do the kidneys appear normal, or they are echogenic? Is there good corticomedullary differentiation, and all those things? Then on the direct criteria now, here now we are looking at all these, the kidneys, the renal arteries from their origin at the aorta to the kidney hilum, and we also assess the aorta itself. In which case, you have to take waveforms at the origin of the renal vessels within the aorta, so that we can have our PI, we can have our peak systolic velocity at that level that we will use to compare with those that we get in the renal vessels, in the renal artery. So the peak systolic velocities should not be more than 180 centimeters per second. So if you have less than, it means it's normal. If it's more than 180, it means there is renal artery stenosis. And peak systolic velocity is more than 200 centimeters per second in the renal artery, in the segmental artery, or in the interlobar arteries. It is a sign that there is more than 60% stenosis. And this is what is critical with ultrasound evaluation. You have to rule out that there is no more than 60% stenosis in the renal vessels. So if there is more than 200 centimeters per second in our peak systolic velocities, already that one is a significant stenosis in these vessels. Then we will be looking at renal aortic ratio. This one is just a ratio or a fraction of the renal RI values over the aortic RI values. That ratio should not give us a value which is more than 3.5. If it has a value which is more than 3.5, it shows that there is significant stenosis in renal arteries. Then we also look at post-stenotic turbulence in the renal arteries, which can be seen using even color Doppler evaluation by those aliasing and the mixing of colors within the renal vessels. And it can be seen on this waveform itself by the form of a Tadas-Pavas waveform. We also look at the absence of flow, both in the kidney or in the renal arteries. The direct criteria now, we'll be looking at all these resistive index and delayed acceleration time, which we also use in the indirect criteria. But in the indirect criteria, the way I put those ones in red, it's is because those ones are not very important in the indirect criteria. We just use them because we will have obtained the waveform and we will be measuring our resistive values within the vessels. But even if you don't use those ones in the indirect criteria, it's not a problem. But those RI and delayed acceleration time is more important in the direct criteria. Right. Then on a detailed explanation of the protocol. So the first thing you have to do is to do a renal survey, which will look at the sizes. That when you see that the other kidney is more than 2 centimeters than the other, we look at the stones, echogenicity, hydronephrosis, or masses, because all these things can also cause an increase in the resistance of the renal arteries. Right, and we also obtain waveforms at the kidney hilum, the upper pore, mid pore, and lower pore of using segmental arteries. So we are sampling segmental arteries in the hilum, upper pore, mid pore, and lower pore. We can also sample interlobar and arcuate arteries, but this may be optional and are usually looked for when there is a significant finding. So what we are recording there is our peak systolic velocity. This is in the indirect survey. So our peak systolic velocity should not be more than 200 centimeters per second. Some departments, I just heard they can just do the indirect survey. If the indirect survey is normal, then they don't concentrate on the direct survey. But according to me, I say that practice is wrong. You have to do both the indirect and the direct survey, even if the indirect survey appears normal. So coming to the direct survey now, you will be looking at the renal arteries themselves, right from the origin at the aorta, in the mid portion of it, and at the distal part towards the hilum. Then that's when we will be comparing with the aortic peak systolic velocity that we have obtained at that level of aortic vessels origin within the aorta, so that we can obtain our renal aortic ratios. So we also look at peak systolic velocities. We're now looking at the acceleration time. The acceleration time is considered as the time to peak, which is the time from the start of that systolic upstroke to the first compliance peak of the wave. Then the acceleration index there, the acceleration index is just like, maybe I can call it dy dx. This is just the gradient, which is the gradient of the rise of that slope on the wave compared to the time on the x-axis. Then the resistive index there, we will be looking at the resistive index of all these renal artery segments. And I've talked about it. Now, let me get into the technique part of it. I'll just try to be brief and quick here. Right, what you have to do is we have to put our patient supine and on the bed, and then we try to localize the aorta longitudinally to the left of the midline. Then we should look for the superior mesenteric artery. Then our renal vessels are usually found 1 centimeter below the superior mesenteric artery. So we will be in the transverse section, and we can see both the left and the right renal arteries arising from the lateral sides of the aorta, 1 centimeter inferior to the superior mesenteric artery. So first identify the superior mesenteric artery, and then 1 centimeter below, look for those ones. Right, in axial plane, you will view the renal arteries in longitudinal orientation, and you can use the lever as a window and angle the probe towards the arteries. So you angle towards the left if you want to interrogate the left renal artery, and you also angle towards the right if you want to interrogate the right renal artery. This technique is very easy in slim patients. Remember, we said we have our limitations in obese patients from the start of this talk. So other techniques that we can use is compression and angulation of the probes. So this is my anterior approach picture. which shows the probe above the abdomen, and you can use color Doppler to see the aorta and the renal vessels arising on the lateral sides of the aorta. This is the flank approach, whereby you have to turn your patient in the decubitus position, whether it's, you are doing the left or the right, and you see the kidney in that position, in that orientation. Okay. Right, from the anterior approach, you can displace the probe to the right of the midline and angle towards the left to see the left renal vein. I think I've talked about this. You can use the left semi-decubitus position. That is, your left side is below and the right side is slightly raised. And you place your probe posterior to the right mid-axillary line in longitudinal plane and angling towards the major vessels. So in this view, your probe is longitudinal and you can see both the aorta and IVC. At this level, you can also see both the right renal artery and the left renal artery originating from the aorta. You can also see the junction of the renal vessels as well. I will show you the picture of this orientation. And in this view, you can also use the lever. The lever will be your acoustic window to see these vessels. We can also obtain Doppler signals and Doppler waveforms at this on this view, but it will be a bit difficult in overweight patients because of the increased depth. So with the probe on this right flank in the coronal plane of the kidney, you can sample the hilum and kidney vessels. Then you use your color to see those vessels. Right lobe access the window. I think I've talked about this. Then you can also do the transverse view by turning your probe 90 degrees. That is, if you have difficulties in visualizing in the longitudinal plane, you also have the liberty to turn the probe the other way, and you visualize the hilum, the transverse view, and the renal vessels. So this is the flank approach. This is the image that should come up when you put your probe just behind the right mid-axillary line, and then try to use the lever as your acoustic window, and you see both right. I'm trying to look for a pointer, so that may be. So that maybe I can use it and show you as I go. Okay, so this is our IVC there, and this is our aorta, and these are the renal vessels. So this is the right renal vessel, and this is the left renal vessel, as you can see them originating from the aorta. This is the left lateral decubitus. In that is the same flank approach again. We are seeing the aorta there and our vessels originating from the aorta. We can sample the proximal segments of the left and the right renal arteries in this position, but this is usually useful in slim patients and very difficult in obese patients. I'm going to talk a bit about the technical shortcuts. These are the keynotes that you need to do in order to obtain very good waveforms, right? So you have to interrogate flow disturbance with color aliasing and pulse Doppler, right? Then you will be looking for the PAVA status waveform. You need to use a very small sample volume. That is your pulse gate should be as smaller, around 2 millimeters, I think, should be effective for this, and always use angle correction of less than 60 degrees. Sometimes if your angle is very wrong, you won't produce very good waveforms there. And the other thing that you need to do is take as many samples to review. So you sample as many times, save as many images as possible. Then when you are doing your measurements now, you have to choose the best of your images and use them for your diagnosis. All right, this image is showing the aorta, because you also have to sample the aorta. But look at that weak waveform that we got there. It was because there was a wrong angle there. So perfectly, this machine actually tells you that the angle is wrong, and it gives you that angle in red there. It's 86 degrees. We need an angle which is below 60 degrees. Now, after obtaining our waveforms, we now need to look at the criteria for evaluating these waveforms, right? So on our indirect evaluation, we just use peak systolic velocities, which we said they should be less than 180 centimeters per second. You will see some text saying 200 centimeters per second, but 200 centimeters per second is used as the upper limit for insignificant stenosis. As long as by the time our peak systolic velocity goes beyond 200 centimeters, it means we have more than 60% narrowing within the renal vessels, and that is very significant. And usually that's what our physicians will be looking for. We look at the waveform. Is it normal or is it abnormal? We'll talk about the appearance of a normal waveform and abnormal waveform as we go. I think it's within the next few slides to come, whereby we say we'll be looking at the rounded, the Pava status waveform that we have been talking about. On our direct evaluation now, we need to look at peak systolic velocities of the renal arteries, both of them right and left. Usually you need to evaluate the proximal segment of the renal arteries, because this is the most region that is affected by renal stenosis. It's mostly affected by atherosclerotic arterial diseases. And this is the most common region, above maybe around 75% of our patients with the renal vascular hypertension. They have stenosis in the proximal segment of the uterine of the renal arteries. So we need to look at peak systolic velocities. We need to look at renal aortic ratio, whereby we are comparing the proximal, the middle, and the distal part of the renal arteries. Then we be using peak systolic velocity of renal artery over peak systolic of the aorta. This gives you the renal arterial ratio, and this should be less than 3. You will also see some text saying 3.5. I prefer to use 3. We also look at the acceleration time that we said that is time to peak, which is time from the start of the systolic upstroke to the first compliance peak, which should be less than 0.07 seconds. I mean, our acceleration index should not be more than 3.5. This is the gradient of that slope of the arterial waveform. So if it's greater than 3.5, it means the slope is a bit slanted, and our waveform will be obviously going towards Pava status. Resistive index should be less than 0.7. And the difference between the resistive index of the right and the left should be less than 0.05. This is the criteria that we should use when you do your measurements of the renal waveforms. This is just a picture of the same that I've been elaborating there. So personally, when I started doing these renal Dopplers, I usually have this picture in my phone. It's a very simple picture that you need to refer before I started memorizing these things. So this one is a very important picture when you're doing renal artery evaluation with ultrasound. Right, we are now looking at the characteristics of a normal renal waveform. it has a rapid systolic upstroke, which is almost 90 degrees to the baseline, right? It also has a low resistance pattern. It has continuous diastolic flow. In cases where there is increased in resistance, we may fail to see the diastolic flow in the waveform. We may have end-diastolic flow. That is an indicator that there's too much resistance within the renal arteries. Then we have an early systolic compliance peak, right? This is the waveform of a renal artery usually have some kind of two peaks. There is a first small peak that you see on the waveform. That is the first compliance. That's the early systolic compliance peak. And there's a second peak that will happen a little while later. But here we're talking of that first peak should always be seen in a normal waveform. If you don't see that first compliance peak, it means there is also increased resistance in the renal artery stenosis. This is just a diagram to show the renal artery. So when you are sampling now, our indirect evaluation will sample the upper pole, the mid pole, and the lower pole. Then you will also sample the hilum. Now, when you are doing the direct evaluation now, you include this and as well as the renal artery itself, whereby you assemble this proximal part from the aorta, the proximal part, then the middle part of the renal artery, and the distal part close to the hilum. This is just an example of a mid-pole segmental artery and the waveform there, and the values there 0.62, which is less than 0.7 for the RI, and the peak systolic velocity is 52, which is less than 200 centimeters per second, denoting that this is a normal finding. This is another picture also which was showing how we assemble the segmental arteries. Okay, this picture I put it so that you can see the acceleration time there, which is 0.038. This is less than 0.07 seconds, which we said is the normal that we require to rule out stenosis in these segmental arteries. This was sampling at the hilum. Right, from this graph here, you can see that there is this peak here, and then there's a little bit drop in the waveform, and there's a second peak there. So this is our early compliance peak that we're talking about. So whenever you are measuring your acceleration time and your acceleration index, it's from the start of this to this early compliance peak, and not this second compliance peak. This was sampling in the proximal renal artery. This is our kidney here, as outlined by my marker there. And this is the proximal segment of the renal artery. So sampling there, then we get our waveform there, and our values as well is denoting a normal finding. This one now is the mid-renal artery sampling, right? This one is a bit difficult because our renal artery is between the bowels, and we need to be very careful in tracking the renal artery. So it was sampled. This is not a kidney, this is bowel, and that is the renal artery. You can see with the waveform there. That's renal artery sampling at the middle segment of the vessel. This is another middle renal artery sampling again. Now, the abnormal waveform now of the renal arteries, it will have a rounded waveform with a delayed systolic upstroke. So instead of having this sharp appearance here, our waveform will be a bit rounded, and our slope here will be a bit slanted. Right, so it will also have some progression, a systematic progression of this waveform, whereby this slope continues to fall, and our upper part of the waveform becomes rounded in form, as progression of stenosis in the renal artery progresses. Apart from rounded waveform with delayed systolic uptake, we will also have absence of early systolic peak. So that compliance peak again, it will disappear as stenosis increases, right? And we also have delayed acceleration time and reduced acceleration index. These ones now are determined by this slope that we're talking about. As long as this slope lands like that, it means our acceleration time is going to be increased and our acceleration index will be more than 3. Okay, we also have absence of diastolic flow, right? So these are identified distal to the stenosis or occlusion, whereby the acceleration time will be greater than 0.07 and the acceleration index will be less than 3. So our dy/dx there, or our acceleration index will be reduced. Some texts may say below 2.7, but below 3 is good. This is one of our clients who had hypertension, and the kidneys were echogenic after the indirect evaluation. You can see that the kidney, the liver there is actually hypoechoic than the kidney. And you can actually see that the left kidney is more affected because it's even more echogenic than the spleen. And so even if you compare the right and the left kidney there seems to be more affected than the right one. So renal artery stenosis can also affect one kidney and reserve the other, or it affects one kidney before it affects the other one. So in this patient, this 1986 guy here, this is the same patient with these kidneys, and this was the waveforms that we obtained. This was in the middle segment of the renal artery. You can see that the renal waveform is a little bit okay, but as we go towards the hilum there, it is becoming to be a bit rounded there. Of course, the early systolic peak is still there, but there is rounding of this waveform, which may be suggestive of some stenosis that was happening, or it due to high resistance within the renal parenchyma, maybe due to other conditions like renal parenchyma disease, or that was affecting that kidney. Right, okay, this slide I was just talking of causes of increased resistance or PAVA status waveform. It's just the same as the first one that I've given to you, which causes increased blood pressure in our hypertensive patient, which renal stenosis is one of them, renal parenchyma disease. These things are the ones that cause our waveform to have that PAVA status waveform and to have abnormal renal Doppler findings. So they include renal artery stenosis, renal parenchymal disease, obstruction, pyelonephritis, renal vein thrombosis, renal masses, renal infarction, renal injury, and transplant. Then we will also have some end-stage renal insufficiency, where we may even have renal artery occlusion, in which case we may find very small kidneys, usually less than 8 centimeters or 7.5 or 6 centimeters long kidneys. These are small atrophic kidneys. The renal artery may not be visible within from the aorta or within the renal parenchyma. We may not be able to find the segmental arteries, the interlobar arteries, or even the arcuate arteries. And then the intraparenchymal renal flow may not be detected. It may be slow or damped flow, or there may be low amplitude flow within the kidney. Then the renal veins are also evaluated in this procedure. However, it has variable appearances. because they reflect the transmitted pulsations from the right atrium. And these pulsations are more pronounced within the right renal vein because it's very close to the IVC and it is very short than the left renal vein, which is a little bit longer and exhibits less of this feature. So the right renal vein is short and exhibits this feature in all cases except in renal vein compromise. When sampled to the left of this superior mesenteric artery shows slight variation of flow velocity. We may also find damped flow pattern, which may be associated with the nutcracker syndrome and reflects venous congestion. This is within the left renal vein. So what we are simply saying is the right renal vein has got more variations than the left renal vein. And also damped flow in the left renal vein may be associated with the nutcracker syndrome. The nutcracker syndrome simply implies that from our anatomy, we said the left renal vein is sandwiched between the aorta and the superior mesenteric artery. So these two vessels may compress the left renal vein and it will have a damped flow. So that is what they call the nutcracker syndrome. This phenomenon can also be described by another perspective whereby that compressed left renal vein will also affect proper drainage of the left testicular vein. Remember, the left testicular vein empties into the left renal vein. So it means there is compromised flow there, which will be affecting the left testicle in males, right? So those affected testicles may be referred to as the nut there, which has been cracked. These are my images for which was showing those variations that I was talking about. This is still our 1986 patient there that I was talking about. This is the right renal vein. You can see more variations in the waveform, and then there is little of those fluctuations on the left renal vein. But what is important there is, so if you see this, it should not sound to you like there is an abnormality there. So from all that we've been saying, what is important is the report. So on a renal Doppler evaluation, we should produce a report which should rule out 60% stenosis, because 60% stenosis is what is significant, right? And that's what our physicians and our referring doctors will be looking for. Is there more than 60% stenosis in this patient? So you should be able to rule out this 60% stenosis. You should describe the grayscale imaging of the kidneys. I think we've been talking about those echogenic kidneys. You also describe the size. Are they small? Are they large? Is there any difference between the left and the right kidney? These are some of the things that we're talking about. Always put the aortic peak systolic velocity, and main renal artery should be evaluated and put the values. You evaluate the origin, the mid region, and at the hilum, then putting peak systolic velocities and diastolic velocities in the RI values. Also report any turbulence that you have seen or any visible stenosis. I know visible stenosis sometimes is not as always, is usually not visible as we may think, but sometimes it can also be seen that there is actually stenosis close to the renal hilum. Then also put the segmental artery values, the peak systolic velocity and diastolic velocity, acceleration time and the acceleration index. I have left the renal arterial ratio there on the main renal arteries. It should be put here. We need to see the RA, and it should be documented. Also, renal artery can be classified. There are three basic classifications that are used, and usually these are done with the help of Doppler scanning of the renal artery to determine the state of stenosis. So the renal arteries are used to determine whether there is stenosis or not. So the first grading is the hemodynamic function or classification. This is the one that us sonographers usually do. After doing our evaluation, we should explain that there is hemodynamically insignificant renal artery stenosis of less than 60%, which is detected by peak systolic velocities which are less than 200. So if you see any peak systolic velocity which is more than 200 in any of the segments of the renal artery, the segmental arteries, the interlobar arteries, then you should document that the stenosis is more than 60%. Then we also have hemodynamically insignificant renal artery stenosis, okay, I said you should say we have hemodynamically insignificant when we have peak systolic velocities of less than 200 centimeters per second, usually less than 180 centimeters per second. Then we should also establish that there is hemodynamically significant renal artery stenosis if our peak systolic velocities are more than 200 centimeters per second. So this is classification using hemodynamic function. Then we have this the hypertension and the renal function classification. Is just an American Heart Association which came about with this grading here, whereby after doing our renal evaluation and we determine there is stenosis or there is no stenosis, then we know whether the patient is hypertension or not, or normotensive, and also we do the renal function tests. These are the three criteria that they use to grade hypertension, renal artery stenosis, I mean. So grade 1 is when renal artery stenosis is present, but the patient is normotensive with a normal renal function test. Everything is normal, but our Doppler evaluation suggests that there is renal artery stenosis. That is grade 1. Then grade 2, there is renal artery stenosis there after our ultrasound evaluation, but the patient is also hypertensive with a normal renal function. That is grade 2. Then grade 3 here, there is renal artery stenosis, hypertension, as well as abnormal renal function. Then the luminal narrowing now, this is done using MRI and CT angiography. I don't know, maybe in the future if we may be able to determine this percentage stenosis using ultrasound, but due to the multiplanar imaging of the CT scan and MRI, they can be used to determine diameter reduction in the renal vessels. So some say when it is normal, it is grade 0, and grade 1 is that diameter reduction between 10 to 30%. Then grade 2 is 30 to 50%, 50 to 70%, and 70 to 99%. And the last grading is occlusion. Right? So this grading may differ. Some may start from grade 1 here, some may start from grade 0, but this is the arrangement. There should be 6 grading there for this luminal narrowing. This luminal narrowing again can be further divided into degree of severity by saying the normal is 0%, then the mild is 1 to 49%, moderate stenosis is 50 to 69, and severe is 70 to 90, then 100%. This is occlusion. This is by using MRI and CT evaluation. I think by this I have concluded my presentation today. Thank you so much.